Thank you for joining us for today's webinar. We do these webinars every second Wednesday of the month, and we choose orthopedic topics that are of interest to our patients and to the viewing public. The topic for today is common shoulder problems, and we're going to focus our discussions on non-surgical treatment options, specifically orthobiologics, like platelet-rich plasma and cell-based therapies from bone marrow or adipose tissue. So before we start, I'll have Dr. Rogers say hi. I'm joined by Dr. Chris Rogers, who's the founder of San Diego Orthobiologics Medical Group, and he will give us a brief introduction on our practice and what we do.
Great, thanks, Dr. Ambach. Pleasure to be with you folks today. Thank you for taking time out to be with us. A shout out to our friends who I know are watching out, not just here in California, but in Texas. Hope everyone's doing well. And to our patients, thank you for joining us each time we do this. I hope you find these enjoyable as well as educational. So Dr. Ambach and I are board certified physical medicine physicians. I think you have a slide on that.
I do.
And our specialty is in non-surgical orthopedic care. And Dr.
I have taken it out. Sorry.
Yeah, just back it up a little bit. And we've chosen to specialize in non-surgical orthopedics. As much as we value surgery and there's a role for it, the vast majority of patients do not need surgery, and therefore we decided to put our efforts there. In addition, it's just so much fun that we have so many tools in our toolbox, and it seems like every year we have something new to offer and learn about. So we're going to teach, we're going to share with you some of the things that we've learned over the past 5 to 10 years that we share with our colleagues around the world. And we just want patients to be aware that these are available today. So as I mentioned on that next slide, we are board certified in physical medicine and rehabilitation. We started this company called San Diego Orthobiologics Medical Group, which we believe is the premier regenerative medicine practice in San Diego. That's been our goal from day one. And we want to let folks know what orthobiologics are. It's the future of orthopedic care, which means we're using cells and cell-based therapies to treat common orthopedic conditions. And this is our office in Carlsbad. Many of you have visited us here. And on the next slide, you can see we have state-of-the-art facility. I love coming to work every day. We have fantastic staff, really smart people. We have a beautiful facility. So I am one of those guys who has a big smile on his face when he gets out of bed in the morning and ready to go to work. So next slide, we have created a state-of-the-art procedure room. That's where Dr. Ambach is seated right now. Yep. And there you can see a cozy bed where patients will lie down when they have their treatments. And on the right, there's a large piece of equipment. We use that's a digital x-ray camera, so we can look at your bones and your joints. And then on the left, you see a black screen. That's where our ultrasound machine can show pictures of your tendons and your ligaments. And that just makes our jobs so much easier, and it makes your procedure more effective and more comfortable. We also have a state-of-the-art lab where I am seated right now. In there, you can see a variety of different pieces of equipment. We have a number of different systems that we use to process cells and make our different recipes, if you want to call them that. There you see Linda, our office manager, creating some platelet-rich plasma in a sterile hood using some validated techniques that we helped develop here at San Diego Orthobiologics. And more recently, we have begun to consistently count cells. So we know that a lot of clinics offer platelet-rich plasma, but the thing that we do differently here at our office is we actually quantitate what's in the soup, what I call the soup. So if we draw some blood and we process the blood, we want to know how many platelets are in that sample. And if you're a doctor doing platelet-rich plasma therapy, you really cannot call it platelet-rich unless you count the platelets and prove that the number is increased, that we have concentrated platelets. That's what makes the treatment so effective. So we have a cell counter there, and then we customize the PRP based on what we're trying to achieve with that particular condition that we're treating. So this is our focus for today. We're going to focus on common injuries of the shoulder. We're going to talk about the non-surgical treatment options, including the orthobiologic therapies. And then most importantly, we want to answer your questions. We have the option for you to type in at the bottom of your screen, you see where it says chat, and you can type in your question there. So if you just mouse over the bottom, you'll see fourth from the left, it says chat. And when you have a question, you just type it in there and we will answer it for you.
You may also say Q&A. That's the same thing. You can put that in there as well. So let's start with a little anatomy lesson here. I noticed it's a busy slide, but this is showing you the shoulder joint, which is our topic for today. And the red marks are the structures that are involved in the most commonly orthopedic conditions that affects the shoulder joint. So you have your humerus, which is your bone, and that comprises the ball in your ball and socket joint here. The joint is lined by a cartilage, what we call an articular cartilage, that provides nourishment and support and cushion to the joint. And that is the structure that is affected when you have osteoarthritis. And we will discuss that in more detail in the next slides. And then you have the labrum, which is the outer rim of the cartilage lining in your socket. And whenever you degenerate the cartilage or the joint, the labrum can get torn or can get degenerated as well. The labrum can also get injured with trauma or instability in the shoulder. And then we have ligaments that support the shoulder joint, or what is also known as the glenohumeral joint. The glenohumeral joint has this very small socket, so it's very unstable on its own. So it depends a lot on the supporting structures around it to keep it stable. One of those structures are the ligaments, and there are quite a few of them around the shoulder. And whenever these ligaments get stretched or strained or worn out, they can create problems by being lax or sprained or even torn. And then patients are familiar with bursitis, and what that is an inflammation of the bursa. A bursa is a sac that contains a fluid cushion that acts as basically a lubricant between your bony structures and the superficial structures of your body, like tendons and muscles, and they're located all over our body. And when the surrounding structures like the tendon gets irritated or injured, then that bursa can get inflamed and you can get a bursitis, which causes localized pain in the region where the bursa is inflamed. We also have tendons, which are connective tissue structures that connects your muscle to your bone. And the biceps tendon is shown here, and also the rotator cuff tendons are shown in this diagram. And these tendons can also get injured by getting inflamed, which we call tendinitis, or getting worn out, as we call it, tendinopathy. And we will discuss that in more detail in the next slides. So we talk about shoulder joint osteoarthritis. There are.
Could I interrupt you for 1 second?
Yes, of course.
We had a question from the audience. Can you go back to your previous slide? So to orient you, this is a front view of the left shoulder. And you see that black line at the top, that represents the skin sloping down. So the right side of the structure would be the left side of your shoulder area, just for reference.
Thank you.
Thanks.
This is yeah, go ahead.
Here, right? Same is true here on this x-ray, the front view of the left shoulder.
That's right. Thank you for that orientation. So we're talking about arthritis. There's many different kinds of arthritis, but what we are referring to is a condition that's called osteoarthritis. And that is a chronic condition that involves long-term chronic inflammation of the joint that eventually leads to wearing out or the degeneration of the cartilage, which is the protective lining of your joint. And some of the X-ray findings that we see, this is the picture that you're looking at is an X-ray of your shoulder joint, is that the joint space gets narrowed when those cartilage gets worn out. You have less of the cushion, so you've got joint space narrowing. And then there's also formation of osteophytes or bone spurs, which is the body's way of basically protecting the joint and creating more surface area to withstand the load that is being given to. So osteoarthritis is very common. You know, as we get older, we're going to get osteoarthritis. Majority of the patients more than 60-year-old will have some form of degenerative arthritis in their joints. So it's a very common finding on imaging studies, and it doesn't necessarily mean that you have osteoarthritis on your x-rays or on your MRI that you're going to get symptoms from it. But some patients do, and that's when we start treating them. We talked about tendon disorders in the shoulder. The most common tendon that gets affected is the rotator cuff. Rotator cuff is this group of 4 muscles that keep your joints stable in place, and they're responsible for lifting your arm up and rotating it inside and out in your body. 2 kinds of conditions that involves rotator cuff tendons are you can either get torn or you can have a rotator cuff tear, wherein this fibrous structure that connects the muscles to the bone gets torn. And most commonly, this is caused by either trauma or degeneration. Or you can have what we call tendinosis or a tendinopathy, which is not the same as tendinitis. Tendinitis means the tendon is inflamed, but when it's called tendinopathy, it means that it is a primary disorder of that tendon wherein it gets overused and worn out, and that you lose the mechanical properties of the fibers, and that can lead to thickening or tear of the tendon, pain, and inflammation. Just like osteoarthritis, as we get older, these rotator cuff injuries get common. You know, the tissues in our body get worn out, and about half of patients more than 50-year-old can have this condition without having any problems in some cases. So most of the conditions that we see in the shoulder can be treated successfully with conservative management. And this includes a lot of things. Self-care treatment is very common. By the time that we see the patients, usually they have treated it in some way. Most commonly, they treat it with heating pad, which can help increase the blood flow to the region. It can help with pain. You also can treat it with ice, which helps decrease the inflammation and helps with the pain. The cornerstone of your conservative therapy is rehabilitation exercises, wherein you strengthen the support structure of the shoulder joint, the muscles, the tendons, the ligaments. So that's important, along with your home exercise program. In order for you to tolerate exercises and daily activities, anti-inflammatory medications can help with decreasing the inflammation, and sometimes analgesics like Tylenol can help. If these initial treatments fail, then that's when we start talking injections to the patients. And it used to be that the only injection that's available to patients are steroid injections. These are the most common injections that patients hear about, because one is covered by insurance, it's widely available. The advantage of these injections is it does provide you immediate relief of pain and inflammation. So patients who have a hot joint or if patients need to undergo physical therapy and they're limited because they're in too much pain, this can help quiet down the inflammation in the joint. The disadvantage of steroid injections, as a lot of you know, is they only last for a short time. You know, most commonly they last for 3 to 4 months. They can last a little bit longer, maybe 5 months, maybe 6 months in some. But the main problem with the steroid injections, it is toxic to your cells, and if you repetitively use this medication or get it injected into your joints or ligaments or tendons, it can actually cause a further degeneration of the tissues. They have found in studies that repeated steroid injections can cause accelerated osteoarthritis in your joints, and it can actually make your tendons and your ligaments more prone for rupture. There's also some systemic effects of steroids. It can affect your hormones. It can make you more at risk for osteoporosis, which is brittle bone. And more relevant in today's time because of COVID illness, steroids can potentially decrease your immune response. So during this time, before we do a steroid injection, we let our patients know and inform them of this possible side effect. And again, it used to be that after all these traditional standard treatments that patients resort to surgery. Now we have an alternative option that's non-surgical, which Dr. Rogers will get into in a minute here. But for those who are candidates for surgery, this is an option for patients who have failed all conservative measures and who are in severe pain that's causing a lot of dysfunction in their daily activities. And more importantly, if their joint becomes unstable and have mechanical symptoms causing instability. Some of the surgical interventions that are used for the shoulder is cartilage repair, tendon repair, removal of loose bodies, cleaning out of frayed out tissue, or joint replacement. As I said, patients who are great candidates for these surgical interventions can benefit from them. It can actually improve pain and range of motion. There are some disadvantages to some of the shoulder surgical procedures, especially for tendon repairs. Unfortunately, there is a high failure rate of rotator cuff repair that has been published. And I think most of that has got to do with the rotator cuff tendons right at the tendon bone interface doesn't heal well or regenerate well after a surgical procedure. It just becomes a weaker tissue. And so we see rotator cuff re-tears really commonly. And there's just no high quality data right now to suggest that some of the surgical interventions are more effective than even physical therapy or our standard conservative treatments. So for these patients who have failed conservative measures and are not great candidates for surgery or do not want to undergo surgery, this orthobiologics or cell therapy is a great alternative option that's natural and would aim to repair tissues or injuries in your body. Dr. Rogers?
And I'm going to talk now about orthobiologics, but before I do that, I'd like to answer some of the questions that I see the audience is presenting. There's some really great questions. Dr. Ambach did a really great review of the standard of care, and that's how it's been for decades now, with those non-surgical options, physical therapy and cortisone being very commonly used. And then in cases where those didn't work, patients were looking at a surgical procedure. And more we're realizing that some of these surgical procedures do not present with long-term success like we would hope. There are cases where clearly surgery is indicated. There are cases clearly where an orthobiologic solution is not the right solution for that patient, and we'll refer those patients to our shoulder surgeons. But more and more, we're realizing that we can treat these significant injuries to the joint and to the tendon using orthobiologics. So I'm going to get a little bit in that detail. But before we do that, I realize that we're all looking at the computer right now. And if you're like me, you're wearing eyeglasses and you're staring at the computer like this, which means your posture is horrible. So realize that your posture does influence the mechanics of your shoulder. Lean forward with really horrible posture. Try to raise your arm. Somebody asked, what about impingement? What's impingement, doctor? Well, Dr. Ambach, what's impingement? It's when you raise your arm and the bones squeeze the soft tissues between them, the soft tissues being the tendon and the bursa. And so if you have a thickened, swollen, painful tendon or a thickened, swollen, painful bursa, and then you raise your arm and it pinches those tissues between your collarbone area and your arm bone, that hurts. I always say when a hard tissue bumps against an inflamed soft tissue, the soft tissue will lose. Now, somebody asked, well, what about shaving out bone spurs? I have bone spurs under my collarbone. That's a surgery that's commonly done. That's called the subacromial decompression. And that doesn't necessarily need to be done as commonly as we once thought as well. The thought was you would grow a bone spur under your shoulder blade and your collarbone, and that bone spur would push down and tear the tendon. Because if you remember looking at that picture earlier, the bone sits right over the top of the tendon. Turns out that's probably not the case. In reality, probably what's happening is they're either independent, not related, or the rotator cuff tendon tear is leading to instability of the joint, putting stress on those structures, leading to bone spur formation. So simply shaving away the bone spur doesn't solve the problem. A lot of times folks look at their x-ray and they go, I don't like the look of that x-ray. I don't like that bone spur. Shaving the bone spur doesn't necessarily solve the problem. A lot of times the pain is not related to the bone spur at all. It's related to the injured soft tissues, those ligaments and those tendons that hold your joint together and allow you to have all this great motion. So how are we helping these folks with orthobiologics? What is an orthobiologic? It's basically a treatment that we use in orthopedic medicine that uses cells, your cells, or molecules produced by your cells. And we're going to talk a little bit more about this now. So the next slide, you'll see that I tell everybody I am no longer a doctor. I am now a farmer because I am planting seeds, cells, right? And trying to get them to grow. So we find an injured tissue, like your tendon, for example, and we'll plant seeds. And instead of planting seeds, we're planting cells. And these could be a platelet cell from your blood, or it could be a stem cell from your bone marrow or from your fat tissue, or one of many other types of cells that have been shown to be helpful in tissue healing. We got to fertilize those cells. Fortunately, both platelets and stem cells can produce their own fertilizer. They produce molecules called growth factors, which help stimulate the tissue to heal. And in the soil, in this analogy, we have what we call scaffolds. There are some cases where there's a large defect in the tissue and you need to bridge the gap. And so you do that with collagen or fat tissue or hyaluronic acid, some other type of biologic that has some substance to it that these cells and growth factors can rest in while they're regenerating the tissue. So here you see on the left a picture of the PRP, which is from the blood, platelet-rich plasma. We'll talk about that. In the middle, bone marrow concentrate, which we'll talk about. And then on the right, adipose tissue, which we affectionately refer to as the mango smoothie. And so it has that nice yellow color to it. But these three biologics, these three cell-based therapies have been studied quite extensively in the body, in orthopedics. They've been shown to be safe. They've been shown to decrease inflammation and pain. They've been shown to improve strength, mobility, and function. And they do this through a variety of very complicated mechanisms, but we will simply just say it stimulates tissue repair, whether it's causing cells to proliferate or turning genes on so that they produce collagen or some other protein, or growing new blood vessels, or even fighting infection. In that we don't treat patients who are infected, but there are cases where patients may have wounds that are infected, and these biologics have been shown to be helpful for that as well. Now, the most commonly used orthobiologic in our practice and practices across the world is something called platelet-rich plasma, PRP for short. And platelet-rich simply means that we're increasing the concentration of platelets. So we take your blood, which has platelets, which are cells in your blood, and these cells produce and manufacture growth factors, which have been shown to stimulate tissue healing. And we can take a small sample of the blood, spin it in a centrifuge, like you see right behind me, for about 5 minutes. And then the layers will settle out. You see the layers there at the bottom are red cells. In the middle are platelets. And at the top, the yellow clear plasma, which is pretty much devoid of cells. It's mostly enzymes and hormones and whatever you had for breakfast today is floating around in that plasma. So that's the liquid component of your blood. It's the red cells at the bottom that give the blood the color, but you have all these other constituents in your blood. And so by centrifuging the blood, we can separate the layers, concentrate the platelets, creating a platelet-rich plasma solution that we can then inject into the injured area to stimulate the healing process. It's important to note that there are many different ways to make PRP. And so we hear constantly from patients who come into our office, they'll say, I had PRP, it didn't work. And when we query them about how the PRP was done, what it looked like, what kind of system the doctor used, we realize that they probably did not actually get PRP therapy. The only way to know is to actually take a sample from the solution and count the platelets. And that's what we do here in our lab right here. That's the cell counter right there. So you'll see what happens if you use all these different systems. So you're looking at 8 different systems that have been developed, and these are approved for use in medical practices, different systems. And look, this is the same patient. All this blood came from one doctor in France. He gave his body to science, and they then used his blood to create 8 different types of PRP using 8 different recipes. And you can just tell looking at them that they're completely different. The second one from the right is full of red blood cells, whereas the one all the way on the left probably has almost no red blood cells in it at all. And I can tell you the platelet concentration varies significantly from one to the other, and that absolutely will influence the success of the treatment. So here's a study where they used one of those recipes to treat swollen, inflamed, irritated rotator cuff tendon. And this is a summary of actually 16 such trials, what we call randomized clinical trial, where one patient would receive PRP and another patient would receive a placebo, such as saline, which is basically water from the ocean that's been sterilized, or a local anesthetic like lidocaine, or the patient receives steroid. And basically what all these studies together have shown is that PRP is superior to all these other kinds of injections that typically are done for a swollen, inflamed, painful rotator cuff tendon. This is a level 1 rotator cuff tendon tear and tendinopathy study where 50 such patients who had failed physical therapy and other treatments received a single PRP injection, platelet-rich plasma, into their tendon. And these patients were followed for a year. And what they showed is that their pain improved, their function improved in 86% of the patients. So the majority of the patients who had failed other forms of therapy were responding to this therapy. Their sleep disturbance, this is extremely common with rotator cuff tears. I myself have had rotator cuff tear. I can tell you the sleep disturbance will drive you mad because you can't lay on that side very well. As many orthopedic conditions, frankly, will drive you mad because you can't get a good night's sleep. 84% of patients were actually able to return to their sport, and probably as important, there were no complications, no adverse events with this very simple treatment. Now, a lot of times we'll hear doctors or cynics, other cynics say, oh, PRP is a placebo effect. Well, I just told you in that study previously that those patients had failed other treatments, and those results were followed for 12 months. I find it hard to believe that somebody who did not respond to other kinds of injections suddenly would have a 12-month placebo response to this treatment. And this study, they compared PRP to simply sticking a needle in the tendon. There's some limited evidence that simply manipulating the tendon with a needle will promote a healing response, just like exercise, which manipulates the tendon, will stimulate a healing response. But it is a weak response. As you can see from this picture, PRP produced superior reduction in pain for, in this study, 6 months compared to that placebo needling group. This is an actual ultrasound image of one of our patients. And so you're looking at the shoulder from the back. That top picture, that black and white picture, is an ultrasound image looking at the tendon. And if you can see towards the middle of the picture, there's a black area where the tendon is showing a tear. The tendon should be white, fibrous throughout on the ultrasound. You see the tear where the black hole is. After injection of PRP into that remarkably large tear, I might add, you can see 4 months later that this particular patient actually healed a significant portion of their tendon, as evidenced by the image below, where you see a lot of white fibrous tissue. And so that's really fun for us. You know, it's one thing for our patients to tell us they feel better and they can do more things, but it's really remarkable for us to see those chronic injuries start to heal. It's almost like they had a chronic wound on their skin. They said, I have this wound that hurts and it's not going away, and I've tried all these things. And then we sprinkle these seeds and these growth factors, and then we watch the wound heal. So with ultrasound, we do that every day. Now, for the larger injuries, for the more severe arthritis cases, for the larger tendon tears or ligament tears, PRP is not going to be as effective. There are some cases where we've had success, but generally the success rate is lower. It's more like 60% of those patients will improve. And some of those patients may need something more powerful, like a stem cell therapy. And stem cells are remarkable. They're a household word. I don't know if you know what a stem cell is, but I will tell you, it's a special cell in your body. We all have them. They're in every part of your body, and they are the repair cells. They are there to repair tissue, and they do this through a variety of mechanisms, extremely complicated. They have the ability to sense the injury. For example, they do not respond to healthy tissue. They only respond to injured tissue. They respond by actually migrating and crawling to the injured site. And then they start manufacturing compounds that they dump into the area that awakens some of the cells in the injured site to start functioning more normally. These cells can differentiate. They can turn into tendon cells or bone cells or cartilage cell. But by and large, in the body, they function as a repair cell.
Sorry.
Yep, you're fine. This is our friend, Dr. Kaplan. The next slide. Dr. Arnold Kaplan there, professor of biology at Case Western in Cleveland, Ohio, discovered and named one type of stem cell that he called the mesenchymal stem cell, which he showed in the lab could differentiate. It could turn into all these different types of cells: muscle, cartilage, bone, fat, nerve, blood vessel. And that was exciting. We thought, wow, here we have this cell which we can just put in the body and turn it into cartilage, for example. Now, since then, we've discovered that the cell does much more. As I already explained, it stimulates healing, and that's probably its more important role in the body. And he doesn't even want us to call them mesenchymal stem cells anymore. He wants us to call them medicinal signaling cells, which means they're little pharmacies. And here's this little pharmacy sleeping. You see the little pink cells, they're sleeping on these small microscopic blood vessels. And then you stub your toe, or you cut yourself shaving, or you tear your rotator cuff, and those cells become activated. And when they're activated, they start manufacturing fertilizer, growth factors, proteins, cytokines, molecules that talk to other cells to jumpstart the healing process, decrease inflammation, fight infection, et cetera, et cetera, et cetera. These cells are found throughout your body, but I don't think you want Dr. Ambach to biopsy your liver or your kidney to harvest stem cells. So where do we get these cells? Most commonly, we find them in the bone marrow and in the fat tissue. And on the left, you see the bone marrow, which looks very much like blood. After all, these are where all your blood cells come from. The bone marrow in every bone in your body is manufacturing blood cells from blood stem cells. But they also have these mesenchymal stem cells, which promote healing of injured orthopedic tissues. It just so happens that as we age, there are fewer of them in the bone marrow. And so for our older patients, we would prefer to use their adipose tissue. Through a simple liposuction procedure, we can remove some fat, which is very rich in these mesenchymal stem cells, as well as other types of cells that have been shown to be helpful for healing.
I'd like to add this adipose tissue is not processed by enzymes, and these are all approved, consistent with FDA regulations.
That's a great point, because we're always asked, when do you use bone marrow? When do you use adipose? What type of recipe do you use? Dr. Ambach just told you that in some clinics, they will use special techniques to digest the fat and maybe release more cells. The FDA has restricted what us physicians in the United States are permitted to do. And so the techniques that we use are compliant with those guidelines. This is a study using a FDA compliant technique that we call microfragmented adipose tissue. You do a simple liposuction procedure. You rinse the fat in that device that you see on the left, which has water in it. It is then agitated to break loose the oils. And then we end up with this nice, clean, washed, resized fat fragment solution, which can be injected. Dr. Striano, a friend of ours in New Jersey, with some colleagues, studied 18 patients with severe rotator cuff injuries, severe joint arthritis, and found that at 1 year follow-up, there were significant improvements in both pain and function. And again, most of, excuse me, I just lost my voice. Read the slide.
These patients did well over 1 year, which is a pretty significant amount of time.
Yeah, these are severe injury. Go read that study. These were severe injuries, and there were no adverse events, so that's great. Excuse me. Now, this is one of those studies where they use the recipe from fat, again, extracting stem cells from fat, but don't try this at home. Don't let the FDA catch you doing this in your clinic in the United States, because it's not permitted. It's not that it's a horrible thing. It's actually an amazing thing. And we are doing FDA approved clinical trials using these recipes, but right now it's not available for everyday use. And what I'm talking about, after they collected the fat and rinsed it and washed it, they then grew it in the lab for a month. And that way you get your stem cell count from 1 million stem cells to about 100 million stem cells, which may be better, still yet to be confirmed. But in this study, they showed substantial improvements in these significant rotator cuff tendon tears, nearly 90% reduction in the size of the tear on MRI. If there's any radiologists in the audience, you can see those MRI images below, showing that the little white defect in the tendon is getting smaller and smaller every month. And we also watch on ultrasound when we do our techniques. But this was a different kind of recipe. We just share it with you because it gives you a sense of proof of concept that stem cells can heal tendons. And this is actually what a tendon tear would look like. You see the before on the left on 2 patients, and then 6 months after, the stem cells from the fat tissue were injected into that tear, and you can see the healing that has occurred in the tendon, where it's nice and white and shiny and has restored its function.
Yeah, these arthroscopic pictures are great pictures to see the structures through a camera. And there's a question here with regards to, can stem cells grow cartilage in the joint? We actually have studies that have published before and after arthroscopic pictures, wherein they showed areas in the joint that has minimal or eroded cartilage that actually improved in thickness using before and after arthroscopy.
You know, I'll just share with you, when I first heard about stem cell therapy, I don't know, 14, 15 years ago, the idea of growing cartilage was not popular. And in medical school, they pretty much told us it was not possible. And so when I first heard that stem cells could possibly grow cartilage, I thought, no, that's not possible. And then I saw some pictures of some animal studies where they had put stem cells in a sheep who had cartilage lesion, or a rabbit, and they were growing cartilage in these animals. And I thought, oh my God, we're going to cure everybody. And then I realized nothing in life is that simple. And so this is why you want to see a doctor who lives and breathes the science of regenerative medicine, because there's a lot of shades of gray, and we know who's a good candidate, who's a fair candidate, who's really not a good candidate, because insurance doesn't pay for these treatments. So you don't want to waste your time and energy and money on something if the success rate is going to be really low. We see a lot of patients, for example, who've been to clinics and the doctor did PRP for their bone-on-bone arthritis, and we tell them, well, we could have told you that that probably wouldn't work. There's a lot of evidence now that shows that when it's that severe, PRP just doesn't have the oomph that it needs to stimulate healing and get pain relief. And so the art of medicine, I think, will just stick with us for the foreseeable future. Although the science, I have to say, has become quite compelling. This is one of those cases where a professional golfer came to me. He plays on the Champions Tour, and he had a full thickness cuff tear. And I told him, well, for a full thickness, large tear of your rotator cuff tendon, you really should talk to a surgeon. And he told me he had, and he didn't like what he heard, and he didn't want surgery. And he was in the middle of the season, the tournament season. And so I told him I had had some success with a couple of patients using cells from the fat, not PRP, but using cells from the fat and injecting it into the tendon. And I said, this is experimental. There's not a lot of published science. And he was willing to be a guinea pig. And we got this amazing result. You can see on the left, this large tear. You can see the needle coming in from the left, injecting the fat cells, which have stem cells in them, into the tendon itself. And then on the right, a year later, you can see the tendon, most of the tendon has significantly healed. He still has some injury to the tendon, but he has no pain. He was able to play golf. He actually won a tournament about 2 months after I treated him, which he would never have been able to do had he had surgery. He wouldn't have been able to return to sport that early. And so again, it's just sort of an anecdotal case, but these cases are encouraging to us, showing the potential of orthobiologic therapy. This is a study that a colleague of ours, Dr. Chris Centeno, who started a company called Regenx, who we have a lot of respect for, used bone marrow derived cells. So they harvest bone marrow from the pelvis through a needle, centrifuge it, concentrate it, and then inject those cells into the torn rotator cuff. And it was a large number of patients, 102 patients, who had failed conservative care. And you can see that they had significant reduction in their pain and disability up to 2 years after treatment. So we have some limited evidence. There's also some, we didn't share any of the unpublished literature other than our own personal cases. We try to share things that are published in medical journals that have been reviewed by colleagues around the world, as opposed to just anecdotal evidence. So this is one of those examples. If you are interested in learning more about our recipes, you can go to YouTube and type in San Diego Orthobiologics. And Dr. Ambach made these really nice videos about how we make PRP, how we make bone marrow, and how we make adipose-derived cells. And it'll give you an idea about the process involved. These are all procedures that are done in the office, sometimes under taking a little sedative. Most of our patients do not. We use a local anesthetic. It's a very comfortable, safe procedure. Dr. Ambach actually treated me. My elbow feels great. Thank you, by the way. So we obviously believe in what we're doing, and we are patients ourselves. And then I'm going to just speak real briefly. This is a software company that I started with some colleagues. It's called Orthobiologics. I was at a conference about 10 years ago, and I was listening to the doctors describe the results they were having. I said, how are your rotator cuff tendon patients doing? And they say, oh, they're all doing great. They're all doing great. Well, what exactly does great mean? So it dawned on me that we really should be documenting the outcomes of all these treatments and not just treating patients and not tracking their outcomes. So all our patients download the app, and every 3 months we bug them, and the app will ask them, how's your pain? How's your motion? Can you play tennis? Can you go back to pickleball? All these things. And so then we can collect the data. We now have over 4,000 patients in our database, and we can query the database. And if you come to us and say, I have a severe rotator cuff tear, what's your success rate with PRP or bone marrow or adipose, we are growing that database and we are very likely to have that answer for you. And by the way, this is an international registry. This is not just our clinic. We have, I think we now have 60 clinics around the world using this software, and it's growing very quickly. So when you go to a doctor, I think it goes without saying that you want to find the best. What does best mean? Well, we want your doctor to be trained with a board certification in a sports medicine or orthopedic specialty. So we are board certified in physical medicine, Dr. Ambach and I. You could see an orthopedic surgeon if they specialize in regenerative medicine, or sports medicine family practice doctor. We want that doctor to be experienced. We want them to have done thousands of cases like we have. We want them to collect data and publish those results in peer-reviewed medical journals or present them at medical conferences so our peers can throw tomatoes at us at the podium and tell us that our data is not good or our science needs to be better. That's how we move the field forward. It's important to know that one size does not fit all. I cannot tell you how many bogus stem cell clinics there are in the United States. They sell umbilical cord stem cells, which, by the way, do not contain live stem cells. And they claim to treat everything from Alzheimer's to Zika virus. So just know that that's not true. It's not a one size fits all. And then, of course, you want your doctor to be compliant with all FDA guidelines, follow the law, and pursue excellence. That's what the rest of that slide said. So right now we'll take any questions. Dr. Ambach, you're on Facebook Live, I think, so you can see the Facebook questions. I see the Zoom questions. Why don't we tackle some of these next?
Okay. Let me stop my share so you can see us answering your questions. First question, how many injections are needed for an injury? So I think we have discussed this in the past, whether it's for joint arthritis or tendon injury or spine conditions like radiculopathy or disc degeneration. There's no concrete evidence as of yet or data with regards to what is the ideal number of injections for your condition. It depends on the severity of the injury, how you responded to the initial injections, and also the patient itself. What other comorbidities do you have? Like, do you have diabetes that decreases your healing response? So a lot of this are all included in the picture for us to figure out what's the best treatment option for you. For mild arthritis, mild tendon injuries, in our clinical experience, they do really well with just one-time injection therapies. The spine is a little bit more complicated. More and more patients now are needing more than one injection for these therapies, especially if we are injecting multiple structures in the spine. And for more severe injuries, again, it depends on what orthobiologic we're using. When we're using the cell-based therapies from bone marrow or fat, almost always these patients do well with just one injection.
I'll share with you, I just recently queried our database because I was wondering about this as well. And 93% of our patients had a single treatment and didn't need anything else. So, you know, that's another reason to see somebody who has experience and can get it right the first time. We don't always get it right the first time. 7% of the time, the injury was more severe than we thought. You know, we're at a disadvantage. We don't have a way of looking at your tendon biology. We can look at the anatomy on the MRI and the ultrasound, but it doesn't tell us, is that a tendon that is depleted of its stem cells already? Or is that a tendon that is still got a lot of good cells in there? So that influences the healing, but we're doing pretty good. 93% of our patients, one and done.
All right, Dr. Rogers, I want to take this next question. Can you give me an oversimplified answer to when bone marrow is used versus adipose?
Oversimplified answer, yeah. So, you know, we like to be evidence-based physicians, which means we like to look at the published scientific studies, and they're lacking at this point. So if we ask that question from the literature, we say, where is bone marrow superior? Where might adipose tissue be superior? We don't have that answer yet, but In general, if you're a younger person, you're going to have better quality bone marrow. If you're an older person, I'm more inclined to use fat. There are some studies that show that bone marrow may be superior for bone lesions. So there are certain cases where a patient has a fracture that won't heal, for example, bone marrow might be superior there. Understand that there's different ways to make bone marrow recipes, and there's different ways to make fat recipes. And even amongst those different recipes, there may be places where making recipe A is better than recipe B. So I can't oversimplify, actually. I will tell you that in general, bone marrow is very liquid, whereas fat is more, has a little more substance to it. So it's harder to inject fat into tiny little nooks and crannies. So sometimes bone marrow is better for that, maybe like a small thumb joint. Although I will tell you, I treated a nice lady yesterday with very severe arthritis in her thumb. This is one of the most common arthritis conditions we see. And I was easily able to get fat cells into her thumb, and hopefully that'll do her a lot of good.
There's a question here with regards to preparation for a patient that they need to do before the procedures. So we do have a nice patient packet information that will detail all the information for pre and post procedure instruction. But generally, we don't want you to be on blood thinners. We don't want you to be on anti-inflammatories. These things need to be stopped a week prior to the procedure. And there's some medications that need to be stopped a week after the procedure as well. These are things that need to be cleared by your primary care physician if it's safe to stop these procedures. Generally, we don't want you to be doing anything strenuous within the first week after the procedure. And that way you can get through the first week of the healing process, which we call the inflammatory process, where most of the time you may have some increased discomfort. So just take it easy during that first week. So the time that you can do these procedures really depends on the medications that you're taking. Do we need clearance from your primary care? But we do these procedures daily in the clinic. Unfortunately, to answer another question here, Medicare or any other PPO insurance is not covering for these procedures yet. There are some work comp insurances that cover for the procedures, but currently they're not a covered procedure.
We're getting a lot of questions about very severe shoulder joint arthritis, and this is a challenging medical condition to treat. Traditionally, again, physical therapy tried to strengthen the muscles, maybe get some motion in the joint, get the pain out of the joint. For many years, I was injecting cortisone, to decrease inflammation into the joint. There are very few studies showing that injecting hyaluronic acid, which is a gel protein, glycoprotein, protoglycoprotein complex that is injected into the joint. Unfortunately, Medicare and insurance does not pay for that. So we have resorted to orthobiologics for those cases because those patients often are trying to avoid a shoulder joint replacement. The success rate, I would say, is fair. I would not characterize it as excellent, meaning that most of our patients get some relief. A few get very significant relief. I'm thinking, of a couple of patients right now that I've treated using either cells from the fat or cells from the bone marrow. I don't really have any evidence to suggest that we've grown cartilage in those patients' joints, but I do think we've decreased the inflammation, maybe helped strengthen the ligaments in the joint and the tendons in the joint. One orthobiologic, Dr. Ambach, that we didn't talk about is A2M. Without getting into much detail, there's a molecule in your blood that's been shown to be good for decreasing inflammation. And this is a very well-researched area. It was actually developed by one of our colleagues, an orthopedic surgeon who used to be at Stanford. And the data is pretty compelling that this alpha-2 molecule that we call for short, we'll call it alpha-2, maybe can help some of these more severe arthritic cases. And I've done a handful. So it's another tool in our toolbox that we're exploring. but I would say we're very early in our understanding of this.
That's right. We have been saying in the past and also in this lecture that your imaging studies, the MRIs and the X-ray, don't always correlate with your symptoms. And we do have patients that are kind of stuck on, is that cartilage there? Is the cartilage grown? But most of our patients, even though there's no improvement in the cartilage in the MRIs, they do significantly well for a year or 2 years. And that's because these cells work in different ways, as Dr. Rogers has just mentioned. Not only do they improve the quality of the tissue, they decrease inflammation, they also kill cartilage destroying cells in your body, and they also help with pain. By intervening with the pain receptors and the pain pathways. So patients do really well with these procedures, even though there's no structural changes that are significant on imaging studies.
One interesting study, and this was done in the knee, and I imagine it would be true in the shoulder, is even though the cartilage thickness did not improve after cells from the fat were injected into that arthritic knee, they used a special kind of MRI that measured the density and the quality of the cartilage. So even though the cartilage did not get thicker, it got denser and healthier. And so this just again tells us how complicated these healing mechanisms are. And there's more to the story than just growing cartilage thickness per se. But going back to Dr. Ambach's point, how many of you have had a cortisone shot and felt great for a day or a week or a month? I guarantee you, your x-ray did not look any better. Your bone-on-bone arthritis looked the same. You did not grow any cartilage, and yet you felt better just for those reasons Dr. Ambach mentioned. The immune system was calmed down. The nerve endings were not being stimulated and irritated by the molecules produced from those immune cells. And this is very similar to how some of these orthobiologics function.
All right, I think we have time for one more question. Dr. Rogers, we have a question with regards to osteoporosis. If you have osteoporosis and you fell on your shoulder, is PRP or stem cell a good option? She is a swimmer for many years.
Well, good. Keep swimming. We want everybody to be active. And remember, we want you to have good posture while you're watching us on this video, because we want your spine to be straight. And swimming is a great exercise for maintaining good posture and getting the shoulder muscles strong. It can be a little irritating to your rotator cuff if you're not using proper technique, but it's not a great exercise for osteoporosis because, as you may know, it's the weight bearing on the bones. So walking, lifting weights, those kinds of things have been shown to help improve the density of the bone. Now, osteoporosis for many patients is a systemic condition, meaning many of their bones are involved. And so we're not going to inject cells all throughout your body. It's just not feasible. And I'm not aware of any studies, maybe Dr. Ambach is, but I'm not aware of any studies where osteoporosis per se was treated with stem cell or PRP injection.
I'm not either.
However, I am aware of a few studies where bone lesions of the hip, it's a little different than osteoporosis, but it's the same concept where you have unhealthy bone in the hip and you inject bone marrow cells into that bone. So you take it out of the pelvis. It doesn't make sense, right? You take it out of the pelvis and then you stick it in the ball of my hip, and somehow the bone grows that way. Really good studies if you catch it early enough that you can turn that around. So no, osteoporosis is not really one of those things. By the way, osteoporosis is kind of like high blood pressure. You don't really know you have it till you either measure it with a bone scan or check your blood pressure in the case of hypertension, or God forbid you have an event. And the main event, of course, with osteoporosis would be you fall and break a bone. So we want you to have good balance, good strength, good cardiovascular health. Don't smoke, don't drink, go to bed on time, do all those things that keep all your tissues healthy. But cell therapy is probably not going to, in the near run, be used for osteoporosis. Who knows what the future holds?
Those are great advice from Dr. Rogers. That will be the best way to end our webinar. Thank you for joining us. Again, we do these webinars every second Wednesday of the month, wherein we get into detail with regards to common orthopedic conditions and orthobiologic therapies. On the first Wednesdays of the month, we open the session with just a 30-minute question and answer, wherein you can ask us any questions with regards to the topic that we have for that time. So stay tuned for our topic for our Ask the Doc series for next month's first Wednesday, Ask the Docs Facebook Live series. Thank you for joining us.
Thank you.